Good morning, or good evening, or afternoon in India. This is Dr. John Bennett broadcasting for India Medical.TV. Tonight we have the pleasure of having Sagar Abichandani. He's a dentist from Mumbai. He runs a clinic, I guess, a business called the Dental Hub. And he's going to take us through a series this week on dentistry and dental related problems. So good day, Sagar.
Hi, good afternoon to everybody. Good morning and good evening to different parts of the people staying at different parts of the world. I'm Dr. Sagar Abichandani. I've completed my graduation from Mumbai, went on to do my post-graduation in Prosthodontics, Crowns and Bridges from India. Also went on to do my post-graduation in restorative and aesthetic dentistry from School of Dentistry, United Kingdom, Manchester. And today we're going to start a series on occlusion. This is something which has always been confusing to most of the people. So the topic for today is going to be an introduction, but we will not restrict ourselves to just an introduction. We will be dealing few other things as well. Okay. So the first slide always talks about where we belong to. These are the few snapshots of our practice back home in Mumbai. Ours is a 3-chair practice. We have an in-house dental lab, cafeteria, children's play section, all in one. That's why it is the hub, the dental hub. We are a team of 6 doctors working full-time. We also have a lab technician with us. And we try our best to give excellent dental care at affordable costs. Coming to what the topic for today is, it's an introduction to occlusion and complexities, which would be taken in due course of action over the next 4 to 5 days. This session today will be dealing on introduction, wherein we will be introducing few terminologies, which is important to know as we progress through the important courses of occlusion. Few determinants of occlusion, that is the vertical and the horizontal determinants, to get an idea as to what we are looking for when we are doing an occlusal rehabilitation. The different occlusal schemes in natural dentition, the different functional tooth contacts, which is optimum, both from a standpoint view from a dentist as well as the lab technician, few concepts, and how the mandible moves. And how does a mandibular movement correlates with occlusion is that when you have mandible moving, that is your lower jaw, which is the only movable joint, when it moves left, right, in front and back in motion, the teeth do contact. Whether you have few teeth, many teeth, or no teeth, when we are rehabilitating, we want uniform contacts. So that is why mandibular movement is equally important. First things first, we all have heard talks about occlusion. Many of us have also attended sessions on occlusion. But still, occlusion is something which is difficult for most to understand. There are many take-home messages, many literature quotations which are given. But what we end up doing is not identifying the problem. Why we're not able to identify the problem is because we do not have the basic background as to what occlusion is. Many of us are even scared to venture into the occlusal field. Why? Because what if something goes wrong? We have nowhere to fall back to. So understanding occlusion is equally important. So if we have to make something constructive, we always go down to the grassroots levels. Understanding the foundations, understanding the concepts, the terminologies. For a prosthodontist, the glossary of prosthodontic terms is a Bible. And we always have different editions of the GPT, which is glossary of prosthodontic terms. So we always use the latest edition to understand what the world talks about. So the first basic definition of occlusion is, it's an act or process of closure or of being closed or shut off, or the static relationship between the incising or masticating surfaces of the maxillary and mandibular teeth or the tooth analogs. Tooth analogs, if it's a crown, it's a bridge, it's an implant, prostheses, or dentures. Mutually protected occlusion or organic occlusion. An occlusal scheme in which the posterior teeth prevent excessive contact of the anterior teeth in maximum intercuspation, and the anterior teeth disengage the posterior teeth in all mandibular excursive movements. Basically, the definitions are only to introduce all of you to the terminologies. The detailed explanations and the understanding would be given to you as and how we take up individual definitions. Anterior protected articulation, a form of mutually protected articulation in which the vertical and the horizontal overlap of the anterior teeth disengage the posterior teeth in all mandibular excursive movements. Anterior protected articulation or occlusion. Canine protected articulation, a form of mutually protected articulation in which the vertical and horizontal overlap of the canine teeth disengage the posterior teeth in the excursive movements of the mandible. Balanced occlusion, the bilateral simultaneous anterior and posterior occlusal contact of the teeth in centric and eccentric positions. Unilateral balanced occlusion or group function, multiple contact relations between the maxillary and the mandibular teeth in lateral movements on the working side, whereby simultaneous contact of several teeth act as a group to distribute the occlusal forces. Centric relation. This definition of centric relation has been modified 6 times. There are almost 11 definitions of centric relation which exist, but the most recent and the most acceptable definition is as follows. The maxillomandibular relationship in which the condyles articulate with the thinnest avascular position of their respective discs with the complex in the antero-superior position against the slopes of the articular eminence. I will be stressing more on this definition because this is the stepping stone. Everything depends on getting a good centric. Mind you, centric relation is something which will not be given by the patient. It has to be established by a practitioner. So I'll just go through the important parts of the definition again. It is the complex, that is the temporomandibular joint complex, is present in the antero-superior position. Not the RUM concept which was given earlier. What is the RUM concept? The rearmost, uppermost, midmost. That concept is not existing anymore. It is the antero-superior position. Very, very important. Second important point is that this position is independent of the tooth contact. Whether there are all the teeth present, few teeth present, or no teeth present, the centric relation doesn't change. So it's important for the practitioner to identify and guide the patient into the right centric. This position is clinically discernible when the mandible is directed superiorly and anteriorly. Mandible is directed, so it's the clinician who directs the mandible superiorly and anteriorly. It is restricted to a pure rotatory movement above the transverse horizontal axis. When I'm saying it's a pure rotatory movement, means the mandibular movement also will have some translatory component. We'll see it as we progress. We have natural occlusion, yes, but there are few differences that exist between a natural occlusion and artificial occlusion. Artificial occlusion can exist in dentures, full mouth rehabilitation, which are either tooth supported or implant supported. Understanding the difference. Natural teeth have got a periodontal tissue and has a proprioceptive feedback because of the periodontal ligament. Artificial occlusion, all the teeth are supported by a common denture base that rests upon the slippery tissue, that is the mucosa. In case of natural occlusion, each tooth can move independently and can migrate slowly to favorable occluding positions. What does that mean? If an opposing tooth has been absent, there tends to be supra-eruption. There also tends to be mesial drifting of the teeth in case the adjacent teeth do not have a contact point or a contact area. However, in an artificial occlusion, all the teeth move as a unit with a denture base. They act in unison. Incising with the anterior teeth does not affect the posterior teeth. That's what everybody does. Anterior teeth is for incising, posterior for chewing. However, try doing this with dentures. You will see that there is tipping of the dentures which happen because they're meant to close and open in one single direction. Balancing side contact is rarely found. If present, considered as balancing side interference. What does it mean? It means that if I am trying to close from one side, the other side will not be closing. That means if there is an occlusion which is occurring where my posterior teeth are contacting, they will contact on both the sides. However, when I'm trying to move to the left or to the right, it is few teeth which will contact on one side, causing all the other teeth not to contact. However, bilateral balancing is a must for balanced occlusion, which is only given for complete dentures because we need good denture stability. Due to proprioceptive mechanisms, a person can avoid premature contacts and interference. However, there is no proprioceptive mechanisms for denture patients. If there are any premature contacts or interferences that occur, it would tend to dislodge the dentures. Malocclusion of natural teeth does not evoke any immediate response. If everybody and anybody sees their occlusal pattern, there tends to be some amount of prematurities and interferences present. But there is periodontal ligament, there are proprioceptors, and you also have the joint complex trying to overtake and overcome these difficulties. However, for complete denture patients, that's for an artificial occlusion, if there are premature contacts, you will automatically affect the stability and to an extent the retention. Non-vertical forces are well tolerated and affect only the side involved. However, it is bilateral for an artificial occlusion and traumatic. Second molar is the favorable area for masticating hard food in natural dentition. However, if we try to replicate the same in complete dentures, there would be dislodgement, too much of pressure, and we get on to the combination syndrome. More importantly, if it's a complete denture patient, we try to have maximum amount of masticatory forces restricted to the second premolar and the first molar areas. Coming to the vertical determinants of occlusion, we have two extremities present, that is the posterior controlling factors and the anterior controlling factors. The posterior controlling factors are your temporomandibular joint complex. They determine how your mandible moves. How your mandible moves determines what kind of an occlusal morphology you want. And the anterior controlling factors are your anterior guidance factors. That is how your front teeth contact. That is the contact point of view. And for the traversing point of view, it is how the incisal edges of the mandibular teeth move along the cingulum and the palatal surfaces of the upper anterior teeth to reach edge to edge and go beyond. So when I'm trying to say this, again, I'm trying to hint at the mandibular movement. So mandibular movement is important to understand when we are dealing with occlusion. Now, nearer the tooth to the TMJ, more the influence of the joint anatomy on the occlusal morphology. How do we understand this? Is that the molars tend to contribute more than the incisors, the canines, and the premolars. So their anatomy, their occlusal morphology, any kind of prematurities, any kind of interferences in lateral excursion can be detrimental. Effect of condylar guidance on the cusp height. I'll get back to this. What is condylar guidance? Because it's the condylar guidance which is the posterior controlling factor. Anterior guidance on the cusp height, the anterior controlling factor on the cusp height. The plane of occlusion on the cusp height, between the anterior and the posterior controlling factor, you do have the plane of occlusion and the curve of spree. Both of these factors would be discussed. Lateral translation. What is lateral translation is, if I am stationary and I am moving my mandible side to side, that is lateral translation. Even if I take it in front, that is protrusion, that is lateral translation. So lateral translation is taken into account in three factors: the amount of lateral translation, the direction of lateral translation, and the timing of occlusal contacts based on lateral translation. How is this important? For example, if I am moving my mandible to the left, so the right side has to move more compared to the left side. So the amount of movement on the right side is more than the left side. Similarly, the direction. If I'm moving it onto the left side, whether I am moving it to the left, slightly to the left, or it is in front with the left component. Timing of the lateral translation is whether there's an immediate side shift or a progressive side shift. All of this will be discussed as and how we progress through the session. Horizontal determinants of occlusion. They deal with the cuspal anatomy, the cusps, the cuspal slopes, the ridges, the fossas, the marginal ridges which are there. What should be the amount? What should be the direction? What should be the inclination? All of this will be touched upon when we do the horizontal determinants. Because in lateral translation, ideally we do not want any interference. So if there is a point contact on the cusp, is an interference. If it is a contact onto the marginal ridge, that is an interference. So the design has to be such that we avoid any interference. Condylar guidance. What is it? It is the posterior controlling factor. What is the condylar guidance? It is the mandibular guidance generated by the condyle and the articular disc traversing the contour of the glenoid fossa. Again, coming from the Bible, Glossary of Prosthodontic Terms, the 8th edition. The condylar path is determined on the patient by the protrusive record and set on the articulator. It acts as a posterior controlling factor. Just to throw some light on this, it is the pattern of the condyle of the mandible and the articular disc moving along the slopes of the fossa. Right? Is this clear? Now, what are we talking about? This is set on an articulator. Mind you, any 3-point articulator is not the articulator of choice. We always have to use at least a semi-adjustable articulator, if not a fully adjustable articulator. Why? Because it's only then we can customize the protrusive guidance, that is your sagittal condyle factor, what is existing in the patient's mouth. And if we want to have the entire occlusal scheme blending with this factor, we have to have basically a semi-adjustable articulator, if not a fully adjustable articulator. Okay, because we have to customize the movements. It is practically impossible to do it on a 3-point articulator or a mean value articulator, because it is okay, good enough for dentures, single tooth restorations, a single unit or a 3-unit bridge, that's it. But as long as you're doing a long span bridge or it's a full mouth reconstruction, we have to make sure we are using at least a semi-adjustable articulator, because it's only then we can customize the same. Condylar part depends on the bone contour of the temporomandibular joint, muscles of mastication, ligaments of the TMJ, and the neuromuscular control of the patient. Why these factors? The bone control, that is the bone contour, is not under your control. Right? What the bone contour exists, it's the same path which will be traversed by the condyle. Muscles of mastication, it is the inbuilt mechanism of the muscles, what we know as an engram of the muscle, the memory, muscle memory. That's how they're supposed to function. So it is again inbuilt. It's very difficult to change that. Yes, we can get some amount of disocclusion. We can break the engram and then try to re-engage that in full mouth, but it is difficult. Ligaments of the TMJ generally limit the extent to which a mandible moves. So they are the limiting factors. And the neuromuscular control. For example, patient is a Parkinson or any other disease, it's difficult to control that. So all these factors are more or less not under our control. So it's only the second factor, that is the anterior controlling factor or the incisal guidance, which is a controllable factor. So the incisal guidance, the movements that we exist, the plane of occlusion, the compensating curves, it is all these factors which can be modified to fit in the frame of the TMJ complex. And what is the frame? The framework has the following heads: the bony contour of TMJ, the muscles of mastication, ligaments of the TMJ, and the neuromuscular control. The average condylar guidance is about 25 to 30 degrees. Why is the average value important? In case there is a discrepancy that exists between the left and the right condyle, there is some amount of discal displacement, some amount of fracture that exists, and we're not able to record everything, we can use the average settings. incisal guidance or the anterior controlling factor or the factor which is under our control. It is the influence of the contacting surfaces of the mandibular and the maxillary anterior teeth on the mandibular movement. The incisal guide angle is defined as the angle formed by the intersection of the plane of occlusion and a line within the sagittal plane determined by the incisal edges of the maxillary and the mandibular central incisors when the teeth are in maximum intercuspation. Now, if you want to actually visualize this, this is the incisal guidance angle. How do we trace that? This goes on to the edge here, goes straight across and along the incisal edges. So the incisal edge of the mandibular, incisal edge of the maxillary form an angle, the incisal guide angle. Okay, now just see the difference of the overlap that we get. We can have a deep bite, again a deep bite, but the incisal angle is widened. And in one more case is again a deep bite, but there is no overbite because the teeth are just not contacting. Same instances, the angle remains the same, but there is a variation. Now, what are the factors on which it depends? Phonetics, aesthetics, shape of the residual ridges, ridge relation, interalveolar distance, and on an average, it's about 10 to 20 degrees. How does it depend on phonetics? Right? Is phonetics important? So how does it depend on that? Right? What is the pronunciation? The F sound. That's when the incisal edges touch the inner vermilion border of your lower lip. F. The S, when the incisal edges come very close, but they don't touch. The Silverman's closest speaking space. Right? Again, if we see V, F, V, all these sounds help us to understand what would be the position of the upper incisal edges. Aesthetics. That's when my smile line, the speaking line comes into position. Again, we have to take into account the age of the patient. Because if it's a young male, you'll have about 2 mm of the incisal edges of the upper teeth visible. Young female tends to show up approximately 3 mm or maximum of to 4 mm. As the person ages, you tend to have attrition which happens and some amount of supra-eruption of the lower incisors. So what we tend to see is that the upper incisal edges are less visible with slight more visibility of the lower incisal edges. Shape of the residual ridge, that's how the slope is being determined. For example, the patient will have rounded teeth, squarish teeth, or a combination of these is determined of the shape of the residual ridges. That's how the following of the ridge will happen. Ridge relation, whether it's the class 1, class 2, class 3, whether it's an edge-to-edge bite or the ridges are in edge-to-edge relation, but we still want to make it into a class 1 relation. So there will be minimal amount of overjet and overbite, but it is possible. Interalveolar distance. If the ridges are huge, there is lesser amount of space present for the denture base and for the teeth. If the interalveolar distance is huge, then we have adequate number of teeth which can be accommodated, adequate space present for your denture base and for your teeth. So what is the difference is, if there is an increased amount of space and the patient has got good flaccidity of the muscles, when the patient smiles, more amount of gingival display will be seen. So all these factors we have to take into account, that whether we need longer teeth, wider teeth, shorter teeth, or we need a longer teeth with still some amount of staining seen into the denture base area. Plane of occlusion. The average plane established by the incisal and the occlusal surfaces of the teeth. It is not a plane but represents the planar mean of the curvatures of these surfaces. It is established anteriorly by the height of the lower canine. Right? Why? It's mentioned. It nearly coincides with the commissure of the mouth and posteriorly by the height of the retromolar pad, usually parallel to the ala tragus or the Camper's line. Christensen's phenomenon. Everybody should try something, right? When you bite, you have most of the teeth contacting, right? And as we try to move edge to edge, that is when my upper and lower teeth are contacting edge to edge, my posterior teeth go in disocclusion, right? That separation which exists in my posterior teeth when my anteriors are in edge to edge, that separation is known as Christensen's phenomenon. Now, when we are doing a full mouth reconstruction, we need some amount of disocclusion, whether it's implant supported, implant retained, or tooth supported. Now, when we have to get the disocclusion, we always should aim at getting uniform disocclusion. So the key for that is doing your own wax ups and having a semi-adjustable articulator, if not a fully adjustable one. Compensating curves, the anterior-posterior curving in the median plane and the mediolateral curving in the frontal plane within the alignment of the occluding surfaces and the incisal edges of the artificial teeth, that is used to develop balanced occlusion. Why do we need this? These are the artificial components of the curve of spree and the monsoon which are found in natural dentition. The curve of spree. What is a curve of spree? It is a curve which begins from the tip of the canine, follows the buccal surfaces of the posterior teeth, following up to the retromolar pad. Okay. Now, what is the monsoon curves? It is the curve which exists buccolingually. Okay. So this gives us an idea as to what should be the position of the teeth and what should be the inclination of the cusps. The primary function of the compensating curve is to provide balancing contacts for the protrusive mandibular movements. Without this curve, it would be necessary to incline the entire occlusal plane at an angle. Okay. The compensating curve incorporates in a properly oriented plane of occlusion, starts with the first molar by raising it at a distal part and continuing this initiated curve with further rise in the second molar. The radius of the curve is the result of the guiding influence of the angle of the incisal and the condylar part. Now, just understand this. This is a straight line, right? Now, this gives us a plane of occlusion. Okay. Now, if you see this part, the mesial half of the first molar is flushed in with the plane of occlusion. Now, the compensating curves begin with the second part, that is the distal half. The distal half is slightly raised so that you have the curve which continues onto your second molar. This compensates for my buccolingual as well as mesiodistal inclinations. I don't have to raise or tilt the entire teeth. This curve is good enough. With compensating curve, it is possible to produce eccentric balance in monoplane occlusal schemes, which is otherwise said to be deficient in this. What is monoplane occlusion? Is that you have teeth in a single plane of occlusion. Monoplane, single plane. So when you have all the teeth in a single line, what happens is there tends to be tipping which occurs. There is no posterior stop which exists in a denture. With this compensating curve, instead of a straight line, that is the plane of occlusion, we can raise the distal half slightly to go above the plane and continue the curve onto the second molar to give it a distal stop. Inclination of the cusps. It refers to the angle between the cuspal incline and the horizontal cuspal plane. Inclination of the cusp is made steeper when the distal end of the lower tooth is set higher than the mesial end. This was just explained in the compensating curve. The distal end of the tooth is at a higher level than the mesial end. The cuspal inclination is said to be reduced when vice versa happens. Thus, tipping the teeth can produce a compensating curve and make the effective height of the cusp greater or less. It's important to do your own teeth arrangement because you get this. If a patient has got any immunocompromised or a medically compromised condition, we have to take into account all these. In a diabetic case, we have to make sure we are giving monoplane occlusion because we do not want to increase the rate of resorption of the residual ridges. But if it's a monoplane teeth, patient will not be able to appreciate the biting forces. So we try to get that with a compensatory curve using the following mechanism. Occlusion in natural dentition is completely different as explained earlier from an artificial dentition. Now that we explained about what exists in an artificial dentition, for a natural dentition, the changes are easier to understand. Why? Because it exists in every single mouth. It's important to note that even a natural occlusion or natural dentition is far, far away from an ideal occlusion. An ideal occlusion is something which is theoretic. It is not present in every single mouth. But we can try to simulate the artificial occlusion as an ideal occlusion when we're doing a full mouth reconstruction. So let us understand the features. Centric occlusion is in harmony with the centric relation. That means when we guide the patient in a centric relation, you have maximum intercuspation. So centric occlusion or maximum intercuspation happens at centric relation. In centric occlusion, the supporting cusps of all posterior teeth occlude with the marginal ridges. So there is a marginal ridge cuspal pattern of occlusion, except for the distal buccal cusp or the distobuccal cusp of the mandibular molars. If it's distobuccal for mandibular, it is mesiolingual or mesiopalatal for the maxillary molars, which occlude with the central fossa of their opposing arch. During protrusion, the posterior teeth should disocclude. This is what happens in most of our mouths. This is what we should try to incorporate in all full mouth reconstructions. We have to get disocclusion, not just disocclusion, uniform disocclusion. Tonic activity of the masticatory muscles should be healthy. During lateral movement, the teeth on the non-working side should disocclude. If I'm taking my mandible to the left, the right side is my non-working side. Okay, so there should be a disocclusion and contact between the opposing canines on the working side either alone or together with one or more pair of adjacent posterior teeth. Now, there is a hidden meaning to this. If I am saying that in my lateral movement, that is, if I'm taking it to the left or to the right, there has to be my canines which have to touch. If it's only the canines which are touching, it is a canine guided occlusion. If it's canine along with few other teeth, it's group function. Okay, but this only happens on the working side. The non-working side still is in disocclusion. The dentition is in harmony with the basal bone and aligned such that the functional occlusal forces are directed along the long axis of the teeth. The basic idea is we always need to have axial loading. That is, forces have to act along the long axis. This is theoretical. Ideal occlusion. When we masticate, we just do not have axial loading, we have non-axial loading also. But we will still talk about how to get axial loading in most of the instances. Adequate occlusal, interocclusal distance in postural rest position. When we are in a resting state, our teeth don't contact. Yes, it's only when we are into this state of occlusion, active biting, active chewing, it's then when our teeth contact. So we need to have adequate interocclusal distance or interocclusal clearance in the rest position. We should have normal masticatory, deglutition, speech, aesthetics, and respiratory functions. How are all of these important? Yes. If it's a normal masticatory movement, we have uniform contact of all the teeth and disocclusion. Deglutition, when we swallow, our teeth do contact. Any interference, there is a compensatory mechanism that tends to act. The muscles, ligaments, everything try to compensate and bypass that interference. Over the long run, the stomatognathic complex is at risk. Speech, we don't want slurred speech. We do not want interferences in our speech when we talk. So we need to have an ideal occlusion because teeth play a role in aesthetics and in function. Okay? No signs or symptoms of pain or dysfunction from any component of the masticatory system. You do not want any muscle soreness, muscle pain, joint stiffness. Now, when we come back tomorrow for a session 2, we will begin with occlusion in complete dentures, basically the balanced occlusion, and occlusion in fixed prosthodontics. That's when we will be starting with the basic concepts of full mouth rehabilitation. Thank you so much for giving me a chance to introduce you all to the concept of occlusion. Tomorrow, we will be building on to what we have started with today. The foundation is done. We start with the construction of the building. Thank you so much.
Very good, Sagar. Thank you very much for this excellent introduction to your series this week. We look forward. So I guess tomorrow we're talking about terminologies used in occlusion. Is that correct? We're talking about terminologies used in occlusion tomorrow, Sagar?
We'll be talking about the occlusion in complete dentures, fixed prosthodontics, and then taking on for the fixed reconstructions.
Very good. Okay, then we'll see. Hold on after I shut the video off. Thank you very much.
Pleasure, John. Thank you.